electrical injury, which
Just
is
1 minute, Aneesa. I'm just going to start. Okay, it's recording. Thank you.
okay. So we'll be discussing about electrical injuries. Basically, it's a small topic, but important topic. So
Yes, yes, you are.
Yes.
So we'll start with a case which we had at one of our bedside hospital last month. He was a 24-year-old male who was an electrical lineman by profession. So he was brought to ER with alleged history of contact with a high tension wire and fall. And he came in arrest. So CPR was initiated as per ACLS guidelines, and ROSC was achieved in 10 minutes. And then advanced airway was established. He did come with an asystole as an initial ECG. And then he had this wound on his back. And then he was shifted to MICU. So this is just a background of how an electrical injury can present to us. Going to the epidemiology. So electrical injuries are not very common. They account for about 3 to 4% of all the burn injuries, but 40% of them can be fatal. They have a bimodal distribution, more so in younger children, and as the age advances, we can see the more incidence of electrical injuries, and it accounts for second largest leading cause of occupational related deaths. And but the surprising thing is that most of them are accidental and 90% are preventable. So electrical injuries are when these happen when a high energy current travels through the body due to contact with an electrical source. They are complex trauma and associated with high morbidity and mortality, and 90% are preventable. So how do we classify these electrical injuries? I wouldn't be covering the lightning injury, which as well is an electrical injury. So they are classified as low voltage injuries, that is less than 600 volts, and high voltage injuries, that is more than 1000. Lightning, the voltage can go up to 1 million, but a high tension wire injuries can have a voltage of around 1 lakh volts as well. So low voltage are common in children. They might be playing and come in contact with this electrical cords or outlets, and usually low voltage injuries are due to alternating AC current, and this is more notorious to be arrhythmogenic. So it can prolong the exposure by causing tetany of the hand. And high voltage, they usually are seen in older children or adults, like occupational exposures when they're climbing trees or utility poles. So before we go into the electrical injuries, we need to know some physics and mechanism. How does the injury happen? So this depends upon what's the amount of current, because current is directly proportional to voltage and inversely proportional to the resistance, as we have read in our physics long time back. So, and many factors define the extent of injury, like voltage, tissue resistance, the type of current, what was the current pathway, and the duration for which the patient was in contact with the electrical source. So the physics, as I said, voltage, like low voltage injuries are less than 600 volts. So what does the voltage actually mean? It's the driving force which drives the electrodes from a high potential to a low potential across the potential difference, basically. So it can be high voltage injury or a low voltage injury, and depends upon the current. Current is nothing but the amount of the electrodes which flow into the body or flow across the potential gradient. It can be a direct current where the flow of electrons is constant, or alternating current where the electron changes cyclically. So injuries from electricity can happen. That was a background of physics and how things will happen, and what do we have to know when an electrical injury presents to us. This is like there are multiple mechanisms which can contribute to the electrical injuries. So it can be direct effect, like we all know that electrical current is arrhythmogenic, it does cause ventricular arrhythmias, or it can present with a respiratory arrest, or electrical current can get converted into a thermal energy. So there are tissues in the body which have high resistance, which will resist the flow of current, like skin, bones, and fat, which will not allow the current to pass through. So you see a lot of skin burns when these tissues come in contact and there is high resistance. So they get heated up, causing more coagulation, necrosis. And certain tissues in the body with low resistance, like nerves and the blood vessel, transmit the current into the body, causing deeper injuries. So other mechanism is electroporation. That is, they damage the pores. They damage the cell by causing pores in it and then causing the cell death and leading to necrosis. There can be secondary mechanical trauma as well. Once the patient comes in contact with electrical source, he can be thrown out because of spasm of the muscle. So there can be other traumatic injuries related to the secondary trauma, like fractures and other internal injuries can be seen in these patients. So mechanism, as I said, like if it's a low voltage current, up to 16 amperes, the patient will feel a tingling sensation and touch and go.
Just one little comment. Remember, please, a ruptured spleen that came from a fall dies a lot faster than any electrical injury or any burn injury. So always remember, if a patient, especially your high voltage patient that fell after handling that wire, always think trauma. Don't think only electrical burn. Think about trauma. And trauma always takes priority over any burn, be it electrical or otherwise. So that has to be a point that's always remembered.
So once the patient comes in contact with an electrical current and it exceeds more than 20 milliamperes, what happens is, and hand is the point of contact, the flexors of the hand are more powerful, and that causes contraction of the muscles, and they go in for tetany. That prolongs the contact of the patient being in, that prolongs the duration of the contact the patient is in touch with the electrical source. So this is called as can't let go current. This is because of the tetany of the muscles which happen. So this is just a slide showing the amperes and what exactly can happen. So if once it exceeds more than 60 milliamperes, the muscles go in for tetany and then go in for a can't let go phase. And once it exceeds more than 100 milliamperes, we see the ventricular fibrillations. And beyond that, the patient can go in for an asystole and arrest. So going by organ system one by one. So cardiac is the most important for us, and that is how they present to us. See, the arrhythmias overall, you see that 15% of the patients coming with electrical injury can have dysarrhythmias, and a wide variety of arrhythmia rhythms can be seen in these patients, be it sinus tachycardia or atrial fibrillation, VPCs. But ventricular fibrillation is most common and fatal. It can occur in up to 60% of the patients. There can be conduction abnormalities, first grade, second grade AV block can be seen. It's postulated that because the right coronary artery lies anteriorly, so once the person comes in contact with the electrical current, it's affected, and that causes the AV nodal blocks. But this doesn't need any active intervention. Once the patient comes with a block, they do subside within no time. And there can be myocardial damage as well from any electrothermal injury or electroporation already explained. And there can be myocardial contusion because of the secondary blunt trauma. and you can see myocardial infarction, though rare. Stress cardiomyopathy or the Takotsubo can be seen. Rare manifestations can be spasm or thrombosis because of the coagulation necrosis once the current flows through the blood vessels. Next would be neurologic. It can affect both your central nervous system or the peripheral nervous system. Central nervous system patient can have CNS depression, respiratory depression if the centers of the respiration in the CNS directly get involved, or there can be respiratory arrest because of the tetanic contraction of the respiratory muscle. They can go in for paralysis. Peripheral nerve injuries are common. Sometimes the patient can have altered sensorium, loss of consciousness, neuropsychological disorders. And when there is altered sensorium that warrants that the patient could have some secondary injuries, you need to think of any IC bleeds or and spinal injuries as well are common in these patients because of the secondary mechanical trauma. So next would be the skin. So we have covered heart and neurological. Skin burns can be superficial burns, partial thickness burns, or full thickness. There's something called as kissing burns. That is when the burns happen at the flexors, flexor creases, or oral burns like in children when they try to bite these electric cords. Or flame burns can occur when the patient comes in contact with the electric wire and their clothing catches fire. They can have flame burns. Or arc burns, that is the picture which is shown in here. They can have charring of the skin, and this can have a deep-seated injury inside the muscle causing myonecrosis.
The issue with kids and burns of this nature, the problem is after we send them out of the ICU, what can happen is these kind of patients can start bleeding because the blood vessels in the area are there's lots of blood vessels. So because of that, they can get into a lot of bleeding. If you send them home, make sure that they get good follow-up and that the family understands that if bleeding starts to happen, that they need to compress that area of the lip and bring the patient back to the emergency room so that the patient doesn't lose an extensive amount of blood. This is a big issue, especially with little children. Parents panic and they don't understand what to do. But the thing is that has to be pinched and held, and then the child has to be brought back to the ER. The other thing is follow-up with ENT is absolutely essential, or a plastic surgeon. But usually, typically, if you have ENT available, that's the way to go. But with the kids, follow-up is exceedingly important. Adults, they will automatically follow up, but with kids, it's one of those things that we pay close attention to.
So as I told about the resistant skin, dry skin offers more resistance to the flow of current. So it gets heated up and causes a burn of the surrounding area and prevents the passage of the current into the deeper structures. So, but if the skin is wet, this resistance can come down drastically, and there won't be much of the superficial burns, but the electrical current gets transmitted to the deeper structures. There can be deep-seated injuries which can be there. So this is just a picture which is showing the kissing burns. We can see it at the wrist joint. That is where the flexor crease is seen. Just for the covering, feathering burn or the Lichtenberg, which is burns which are seen in light. So burns are most common. Skin burns can be seen at the site of contact and the body part which is in contact with the ground where the potential is low. So it takes the least resistance path, and skin burns typically underestimate the degree of internal thermal injury which is caused there. So minor surface injuries can have massive muscle coagulation and necrosis with internal injuries. So there can be there can be tissue injury because of bones getting involved. There can be periosteal burns or destruction of the bone matrix. What happens is bone has a high resistance, so it gets heated up, and the structures which are around the bone get major injury. They sustain major injuries, thermal injuries. And next would be compartment syndrome, like the part of the body which has come in contact with the electrical burn, electrical source, can have deep-seated thermal injury, and they can have massive muscle necrosis and go in for a compartment syndrome. So you have to be vigilant with the limb, because it will be limb saving if you can identify compartment syndrome early. And compartment syndrome along with massive tissue necrosis can lead to rhabdomyolysis, that is pigment induced kidney injury, which can happen because of the myoglobin which is released into the circulation, which can block the renal tubules and lead on to multiple biochemical abnormalities like hyperkalemia, hypocalcemia. There can be worsening of renal function. So you have to be vigilant with all that. So CPK, the creatine phosphokinase, is usually monitored with such kind of patients, and it does correlate with the injury and the need of surgery. I'm talking about the CPK values. Next would be secondary trauma, as we already mentioned, that fractures from the fall or after being thrown off from the electrical source or because of the repeated muscle contraction can be seen. And there can be AKI because of hypovolemia or pigment-induced injury to the kidneys by rhabdomyolysis, or hypovolemia because of suboptimal hydration in these patients, because the superficial burns will not estimate the deeper injury which the patient is having. There can be vascular or thrombotic injury because once the current transmits to the blood vessels, there can be coagulation, there can be thrombosis of the blood vessel. They can lead on to aneurysm formation and rupture as well. Gastrointestinal injuries, there can be paralytic ileus, they can complain of some abdominal discomfort, abdominal pain, tenderness. It has been noted that few patients have gone to develop complications like fistula formations or perforations, and there can be solid organ injuries as well, as Dr. Akhil already mentioned. So once the patient presents to us, like the patient who presented to us in arrest, so these patients can present with an arrest situation. So whatever be the rhythm, regardless of the initial rhythm, you need to start your CPR. The pupils might be dilated because of autonomic dysfunction. So you still have to continue. Prolonged CPR is recommended in electrical injuries coming to us with a cardiorespiratory arrest. So you have to start your CPR as per ACLS guidelines. There is no change in treating of arrhythmias in electrical injuries. It is as per ACLS guidelines. I won't be going into the details of each and everything. And the patient might resume the electrical activity, cardiac activity, but there might be absence of respiratory activity for a long time because of the respiratory paralysis. As already discussed, that it can cause depression of the respiratory centers, or because of the tetanic contraction, they can go in for respiratory paralysis. And not to forget your trauma. It is a type of, as I already started my discussion saying that electrical injuries are a complex type of trauma. You should assess as per your ATLS protocol, your A, B, C, D, E, and it should be rapidly assess and stabilize your airway, breathing, circulation, and immobilize the cervical spine given the risk of secondary trauma. And if there is an altered sensorium that should point out that there could be secondary trauma, you should consider imaging the brain. If the patient has hypotension, there could be thoracic injury or any internal abdominal solid organ injury, this has to be taken care of, and a clinical assessment of each and every body part has to be done. And the surface finding may not coincide with your internal injuries, so never be deceived by your superficial burns. Volume resuscitation is of utmost important in these patients, because if we use the resuscitation formulae which we use for our burns, it might not hold good. We are suboptimally hydrating these patients. Parkland formula will not hold good for this. They might need as high as 1 liter per hour of fluid resuscitation because of the internal massive tissue necrosis which is ongoing, and the rhabdomyolysis could be there. So you have to target your urine output of around 1 ml per kg per hour in these patients. GI prophylaxis, yes, because burns patients are more prone for developing gastric ulcers, and more so electrical burns are have higher incidence of the curlings, that is gastric ulcers, than any other burns. So you should keep them on GI prophylaxis. And monitoring the vitals, heart rate, BP, urine output, and biochemical parameters as mentioned. Renal function test, creatinine has to be monitored. Your electrolytes, potassium, they can go in for hyperkalemia, hypocalcemia because of rhabdomyolysis. CPK to be monitored, as already mentioned, that it does coincide with the muscle severity of the muscle necrosis and the need for surgery, and you have to hydrate these patients adequately to prevent them going in for AKI. And monitoring of the limb for any compartment syndrome. Be watchful for the color changes, blanching, pain on passive flexion or paresthesias, and treat accordingly. And the cardiac evaluation and monitoring is recommended, warranted for at least 12 to 24 hours. ECG changes, as I said, can be wide variety of arrhythmias which can be seen. It is not specific that this ECG change coincides and it is electrical injury. So nothing is specific here. So you have to monitor your serial ECGs. Continuous cardiac monitoring is needed, and whether we should be monitoring the enzymes, cardiac enzymes, CKMB might not be, because there is a tissue injury which is happening, it would be high. So they say that troponins can be monitored in a serial manner, and an echocardiography has to be done so that we know what is the baseline LV function, and whether there is any sign of stress cardiomyopathy which is ongoing there. And wound management remains the same as for any thermal burns. The superficial burns would be treated by local antibiotics, dressings, and all that. So deeper wounds, if they are full thickness skin burns, or going for being vigilant with compartment syndrome, they can need fasciotomy. They might, if the wound is becoming stiff, they might need ischiotomy. There will be need for extensive skin reconstruction in the whole course of stay, and sometimes if the limb is not salvageable, they end up getting amputation. So always have a high index of suspicion for deeper injuries, even if the patient just presents with superficial skin burn. So am I clear till here? So just for the it's a short topic. I'm almost at the end of my presentation. So just for the completion of the case which we started with. So this gentleman had advanced airway established and lines established, and then was shifted to MICU. And then post being shifted to MICU, he was started on vasopressors. He was hemodynamically unstable. And then he was on dual vasopressors, and his chest was, the breath sounds were less on the right side, and the chest movement was not adequate. So with a clinical anticipation that this patient could be having a hemothorax, so hemo or pneumothorax. So ICD was placed immediately. Post placement of ICD, he had 1.5 liters of blood which was drained out from his thoracic cavity. So he had hemothorax. He had worsening hemodynamics with drainage of the hemothorax. So it was ongoing bleed. So a massive transfusion protocol was activated, and the cardiothoracic team was involved. And then he was immediately rushed in for OR for a thoracotomy, where they found that he was bleeding from the intercostal vessels. So the ligation of these vessels was done, and hemostasis was achieved, and he and he had CPK values of around 4,500 just for the completion that he did have rhabdomyolysis. So once he was stable from the OR, he was shifted to imaging, because we had not done any imaging till now because he was hemodynamically unstable. So he was shifted to the CT suite.
The only thing I wanted to add was, remember, please, this is a very important lesson that we tell everybody. If you put in an ICD and the blood coming out is more than a liter, this patient needs a thoracotomy, and usually it's an intercostal vessel. It's not the lungs. The lungs don't bleed. It's always the intercostals that bleed, because you usually have a rib fracture or something that's causing the intercostals to rupture and bleed. So that's something to keep in mind. And again, getting your surgeons involved early. Massive transfusion protocol is nice, but if you have an intercostal that's bleeding, you'll never catch up. So it's something to keep in mind.
So he was shifted to CT suite. CT brain was normal. Abdomen didn't show any free fluid, solid organ injury, but the spine did have a complete transaction of T11-12. So this patient was shifted to a higher center for the further management, because they wished to go. And it was almost like 24 hours since the injury. So this case, why did I present it and tell all these things? Because this patient did have just a superficial burn of the back, but he did have a hypotension, which was out of proportion. Then he did have thoracic injury, which was there. He did have massive deep necrosis, because of which his CPK was high. So because of his bleeding, he was on massive transfusion protocol. And then on imaging, we got to know that he had secondary mechanical trauma. That was, he did have a transaction of the spine fracture as well was seen. So all that we discussed was seen in this patient.
Excellent presentation.
Thank you, sir. So you want to add on anything from your experience regarding?
No, the only, like I said, the only thing I want to convey is, don't forget about trauma. And with electrical burns, it's always burn from the inside out. That's the easiest way to remember. It is not from outside in like other burns. This is inside out. So because your muscle will burn long before your subcutaneous tissue or your skin will. So what you notice on the outside, even if you see a little bit of blistering, oh, it's nothing. Think about what's burned on the inside. That's the problem. And get your surgeons involved early. Don't wait. The longer you wait, if that inside muscle that's dead now starts getting infected, you're going to have a heck of a time controlling the source. So that's going to be the issue for you. So you have to be very cognizant of that. And again, one more emphasis that Aneesa absolutely mentioned is pulmonary function does not come back. Even when the cardiac function comes back, pulmonary function return takes longer. So they may be apneic, even after ROSC, they'll have ROSC. They may be apneic. You may not be able to get that pulmonary function back for at least another couple of hours or so. Be patient. Don't be in a hurry to say, oh, this guy is not breathing at all. He's probably dead. No, he's not. Just be patient.
Can I have a word, sir?
Yes, sir, please.
Dr. Aneesa, it was a very excellent talk.
Thank you,
And
sir.
the credit goes to initial resuscitation and shifting to MICU was an excellent and fast work done by intensivist at that time. And second thing was Dr. Subbarao took it very fast and thoracotomy was done. And bleeding was not only from the intercostal vessels, and it was from the tributaries of the azygous vein and the paravertebral vessels. So he had to go beyond the parietal pleura and ligate the vessels. Then only the bleeding was stopped. The other thing was there any role in this patient? You mentioned about thrombosis of the vessels. The heparin was given or not? I forgot to follow up. Then other thing was there any role of prevention of gas gangrene? Gas gangrene usually occurs when there is a contamination of the wound. That's why I just wanted to have a word from you.
Anticoagulation, I don't think was started. He just stayed with us for, I think, for a few hours, and then he was taken to the OT, and he was still bleeding. So anticoagulation wasn't started. So, and he was covered with antibiotic coverage as well. So, and we lost in touch with him after 36 hours, I guess. Yes,
Yeah.
sir.
Yeah, that's true, doctor. And even the patient's attenders were very keen to shift him prior to the thoracotomy. And intensivists and all the panel of doctors explained them. He may not be able to travel more than 30 kilometers. Then only they decided to go ahead with the thoracotomy in our center. Ultimately, the good decision was taken and the patient was saved. That was good. What I wanted to share with you.
Yeah. Yeah, Dilip.
Yeah, Aneesa, intermittent compression devices or foot DVT pumps are available there, right? For such patients who we can't immediately anticoagulate.
Yeah.
So that is the prophylaxis strategy that we could apply here, right? Because of the bleeding, we couldn't immediately give heparin.
Yeah.
And also, there's no role for preventative antibiotics. I think we gave it regardless, but gas gangrene doesn't get prevented unless it's a contaminated wound, right?
Even in contaminated wounds, I'd be very careful. I would debride. Aggressive debridement is indicated. However, again, prophylactic antibiotics more than 24 hours are not indicated. The other thing is as far as, the SCDs, we love to talk about SCDs. We love to say that it is in surgical patients, and this guy is a surgical patient by the fact that it was a trauma. In surgical patients, if you look at the most recent American College of Chest Physicians guidelines, it's that far, but they said, the effectiveness of SCDs is limited. But really speaking, but for the first 24 hours, I agree. You don't use anticoagulants. You stay away from them, obviously, because the patient is bleeding. Once the bleeding has settled and stopped, there is no more bleeding. I think after 24 to 48 hours, starting prophylactic Lovenox or heparin sub-Q is very appropriate, and I think that's a reasonable thing to do. Pharmacologic prophylaxis always trumps SCDs. I mean, SCDs, I know they're historical. We love them because they've always been there. But really speaking, in surgical patients and trauma patients, the effectiveness is almost nil.
Dr. Aneesa, did you? I could not follow this patient anymore after that. Were you able to follow up this patient? What was the current status if he has survived?
He succumbed, sir. He passed.
Oh my God. After how many days?
This was after 3 days after we shifted, like 72 hours.
Okay, doctor. Thank you so much for your talk. It was excellent.
Where was he shifted to?
St. John's, Bangalore. St. John's. So initial assessment, resuscitation is very important in these patients. And this case was managed at our bedside hospital, and our intensivist, Dr. Rajesh, did a great job with this, and the surgical team as well. But unfortunately, the patient couldn't make it. Okay, if there are no more questions, can we?
There's one last thing. When you guys are having discussions with the families, the continuity of care with regard to these patients is extremely important, especially if the patient already underwent the operative part. And at this point, all it requires is aggressive ICU. I know families are not always, they don't always listen. But the thing is it is important to tell them that, a lot of these patients within the first 2 weeks after this type of injury will succumb. Remember, the mortality curve is that's that additional modal distribution of over time, right? Just like any other trauma. So with severe trauma, the death is either very early within the first few hours or within the first 2 weeks. And usually during the first 2 weeks, it's related to sepsis. So, and succumbed. I mean, this is the, and being in the hands of, and you guys should say this, being in the hands of experienced intensivists, the probability that they'll survive is much greater than being in the hands of inexperienced or, less experienced intensivists. Let's put it that way. So that when we're conveying this information, don't be, I always tell people, don't be humble. This is not a place to be humble. This is a place to tell people that, listen, we are the only chance that, this person has to survive. Give the person a chance to live, and put it that way. I mean, you can say you can go to the best intensive care, but if there is no continuity, you're going to lose that person because they won't know what exactly happened at your hospital in Davangere and what exactly was done. And that handoff part is still, not there in transfers and so forth. So that becomes a real issue.
Okay, thank you, everyone.
Great talk, Aneesa.
Thank you.
Thank you. Thank you.
Thank you, ma'am.
Thank you, everyone.